So welcome everyone to COPA's Fireside Chat. This is really designed a little bit differently than other webinars that we've done, in that it is that we want this to be casual and interactive. We're going to offer up information, but there's also going to be opportunities to answer questions. So if let's just take a brief moment for some introductions on the COPA side. So my name is Spencer Greene. I'm a clinician by training, but also the current president of COPA. Linda?
Hi, I'm Linda Collins. I am not a clinician by training, but am reimbursement coding compliant and been on COPA for multiple years.
Indeed. Bryce?
Good afternoon, everybody. I am Bryce Docherty. I am your COPA lobbyist up here in Sacramento, and I've been serving as your lobbyist for 18 years.
Very good. Trevor?
It's Trevor Townsend. I'm a clinician and business owner, small practice owner in Bakersfield, California. And I've been on COPA board since 2016 and sit on the government affairs and membership committees.
Excellent. Thank you. Luis?
Thank you, Spencer. My name is Luis Mora. I'm a certified prosthetist. I work for OSER as a clinical specialist, and I've been elected to the COPA board just recently, so I haven't been serving for that long yet. I also serve on the membership committee alongside Brendan Erickson.
Fantastic. Okay, so the person behind the COPA logo is Danny. Danny is part of Huntington, which is COPA's management team. She helps us with logistics and just about everything under the sun. So thanks, Danny, for organizing this. So let's kick this off here. We wanted to gather or to offer up some time so that we could discuss COPA's advocacy efforts and to talk about where we're at with advocacy and also to talk about this MCO tax. As I have become more involved with the legislative side of our industry, I've learned all kinds of new acronyms. One of them is MCO, and this is just not a familiar term to most. So we'd like to kind of unpack that for everyone. Let me just kind of give a brief overview, and then Linda is going to facilitate some questions for the panel, and hopefully that will spark some discussion amongst the rest of us. So, COPA is keeping a steady hand on the wheel when it comes to advocacy. We feel like we are an independent party that has no financial interest in improving access to care, improving reimbursement. And so this is the association that is probably in the right position to move forward with overhauling O&P reimbursement from the state. And so our efforts have been largely, there's been a lot of grassroots efforts, one-on-one meetings, meeting with key legislators, getting information out there, but also, gathering support from the field. We've done a rally on the steps of the Capitol. So this has really been a well-rounded approach over years. Specifically over the past 5 years, we've been collecting data, putting together a strategic plan, and executing. And that has led to a lot of good activity, identifying legislative champions, testifying in front of the Senate Budget Subcommittee on Health. So a lot of good activity. And we're going to keep fighting the fight because we believe it's the right thing to do, and we want to help move our little industry of O&P forward. So, Linda, let me turn it over to you, and maybe you can ask some questions of the panel.
Well, I'm going to ask Bryce to start us off. And Bryce, if you can just bring us all up to speed on what the MCO tax is.
Sure, Linda, I'd be happy to. So, as many of you probably have heard in the news, California is once again experiencing a tremendous budget deficit. The deficit for this fiscal year is about $20 billion, and the fiscal deficit going into the 2024-25 budget year is about 27 billion. So in total, depending upon who you ask, it's 45 to 50 billion dollars that we have to bridge. What COPA has done over the last several years is have been advocating for an increase in Medi-Cal reimbursement rates for orthotics and prosthetics. And I think what people have to understand is I think you do understand, but the reimbursement in Medi-Cal for orthotics and prosthetics, they're both two separate categories in the Medicaid program. We call it Medi-Cal because we like to put a nice fancy name on everything. But orthotics is a category and prosthetics is a category. The rates have not been increased since Buddha was a baby. We have no idea the last time that rates were technically increased. So the reality is the reimbursement for orthotics and prosthetics is not obviously directly to the provider, it's per device. So our angle has been always patient-centered. It has always been around increasing access to orthotic and prosthetic care to Medi-Cal patients, which are obviously some of our most vulnerable patients in California. 50% of the children in California get their care through the Medi-Cal program. And so we have been trying for years to get a portion of the state's general fund dollars to increase O&P rates. Now, the general fund, we're on a fiscal year budget cycle, so it goes from July 1 to June 30th. And we have been asking for an increase in our reimbursement rates to at least 80% of the Medicare allowable rate. California currently reimburses orthotics and prosthetics at about 49% of the prevailing Medi-Cal rate, Medicare rate, and the national average is about 75%. So we've been asking for at least 80% increase, at least a reimbursement up to 80% and exceeding 80% of the Medicare allowable rate. The arithmetic on that is about $28 million. And this is data that we received from the Department of Healthcare Services, which administers the program. And we've combed all of the L codes, we've crunched all of the data, and our arithmetic shows this is a $28 million request. Half of those dollars, 14 million, is a state obligation that comes out of the general fund. The other $14 million comes as federal matching dollars from the federal government through the Medicaid program. We get a dollar per dollar match for Medi-Cal reimbursement. As you can imagine, we're not the only people that have a woeful, inadequate, long-standing, not updated fee schedule. We're competing for increased funding with the California Medical Association, Physician Services, the California Hospital Association, the likes of Planned Parenthood. Some of the biggest advocacy organizations in California are all clamoring for general fund dollars to prop up the state's Medi-Cal program, because everybody admits, even the governor and even the legislature, that it's woefully inadequate. And what our data has shown us from the state is that the current reimbursement rate is not actually meeting the current needs of the beneficiaries in the Medi-Cal program. We've got data that shows the number of claims in the Medi-Cal program for O&P, the number of unique beneficiaries that are receiving O&P in the Medi-Cal program, juxtapose that with the number of O&P providers, which are all of you. What the data shows you is over a 10-year period, there's been a 3 to 4x increase in the total number of Medi-Cal claims for O&P, and a similar increase in the number of unique beneficiaries that are receiving O&P services in the Medi-Cal program. If you juxtapose that with the number of providers that are providing those services over that 10-year period, it's largely remained stagnant. So what the data shows us from the state's own data shows us, it illustrates what we know is happening. We have demand is exceeding the supply of providers who can financially afford to provide the care, period. With the MCO tax in particular, MCO stands for Managed Care Organization. So 99.9% of the Medi-Cal services that are provided in California are through a Medi-Cal managed care sort of arrangement. Now, it depends upon your particular county. For example, if you're in Orange County, it's provided through CalOptima, right? If you're in Sacramento County or San Diego County, that is an open, competitive commercial market. Any health plan can apply and get awarded the ability to provide Medi-Cal managed care services in those counties. Other counties have a dual plan model, which there is a county model juxtaposed with a commercial model. But all of those Medi-Cal managed care arrangements have to go through a bidding process through the state, and they get awarded the ability to provide Medi-Cal services through a Medi-Cal managed care environment. So MCO stands for Managed Care Organization. There is a ability, and we used this a number of years ago under Jerry Brown, it's technically not a tax. It's technically a fee, but we call it a tax. It is an assessment that is levied on these managed care organizations in the Medi-Cal program on a per patient per month ratio. And I don't pretend to understand, nor do we have enough time to explain the arithmetic and the mathematical gymnastics that goes into assessing the fee. But the reality is the fee that's assessed on these managed care plans on a per patient per month basis allows the state to apply to the federal government to get a waiver from Medicaid in order for us to draw down matching dollars, and in some instances, even more dollars for specific services to provide increased access to the Medi-Cal program. This past year, the last budget cycle, the state of California, instituted another managed care organization tax. And that's intended to infuse the state budget with billions and billions of dollars to go directly towards increasing Medi-Cal provider rates. And last year, the legislature agreed the first tranche of funds for an increase in Medi-Cal rates was going to primary care, labor and delivery, and non-acute behavioral health services. That is a 5-year commitment. Those rates went up to about 87.5% of the Medicare rate. And those rates and those reimbursements are currently flowing. The legislature and the governor's office last year also agreed on a longitudinal program with regards to investment in the MCO tax to fund additional services. And that's a cascading schedule over the series of the next 2 to 3 year budget cycles. So for orthotics and prosthetics, we qualify for the tranche of funds that will be was intended to be distributed this year for hospital and other hospital-related outpatient services. So we have put ourselves in the hospital outpatient-related services category. There's $450 million available in that bucket to increase rates in that category. But as you can imagine, we're competing for those funds alongside ambulatory surgery centers, other primary care clinics, chiropractic, podiatry, anything that's outpatient related is eligible for the tax. So that's really what we have been focusing on, and the strategy and the tactics by how we go about obtaining those funds is kind of what we will elucidate later on in the webinar. But for purposes of the MCO tax, it's an assessment fee, a tax, if you will, on those Medi-Cal managed care organizations to increase the per patient per month spend that they have to make, which allows us to draw down additional federal funds to increase access to Medi-Cal services in California.
Lots of information there, but it's good. It's a good background. Thank you. I know we've had a couple of people ask us questions. So with this MCO tasks wavering out there potentially, what's COPA doing about it? And for those of you who were not involved or hadn't read about it, we did have a big day at the legislation in Sacramento. And Spencer, do you want to fill us in a little bit on what that was all about?
Yeah, Linda, are we talking about the rally or the testimony?
Rally.
The rally.
The rally, yes.
Yeah, so for those that weren't able to make it, COPA organized a rally on the steps of the Capitol. It was picturesque, you know, it was the big dome in the background, and we had approximately 100 people gathered. Local news station, the NBC news station was there. We had two patients give their testimony. A physician from UC Davis as well also offered up his perspective on the importance of orthotic and prosthetic care. And what this did is it just was a great way to raise awareness, especially with the news there, who covered it in the media, to show the activity, to talk about orthotics and prosthetics, and why this care is meaningful to its recipients. And so the purpose here, it was very intentional the way that we put this together to get the word out, is because many people outside of our field don't know what O&P is. They don't understand what we do, and they don't understand the impact on the lives of those that need devices. And so one of the broad aspects of what we're trying to accomplish here is just raised awareness of O&P. We, relative to the rest of healthcare, we're rather small. And so COPA is trying to raise our voice, trying to raise the volume of our voice to represent who we are and what we do. And that was really the take home of that day. Our mantra was mobility saves, and we were demonstrating that investment in orthotic and prosthetic care actually leads to greater savings in other parts of healthcare. So if you invest $100, you actually save $150. The math isn't quite that easy, but that's in general how this works, and we have data to support that. You know, less ER visits, less pain medication, less reliance on social services, so on and so forth. So it was exciting. It was fun. It was, as far as I know, the first event of its kind, and I hope that the awareness was raised as we intended.
Yes. One of the things that we did after the rally was go to meet in smaller groups with some of the individual assemblymen and women and their staff. And Luis, I know you were in one of the groups. Are you willing to share a little bit about what that was like and what kind of messages we were able to share?
Sure, Linda. It was a very unique and interesting experience for myself. I'd never been involved in anything like this. So immediately following the rally after lunchtime, we had a series of meetings set up, and we split off into groups, small groups. I was accompanied by Trevor Townsend, who has a clinic down in Bakersfield, California. And I was also accompanied by one of his patients. And we went and we talked to a variety of assembly men and women, like Linda mentioned, different representatives throughout the state of California. These were all small scheduled meetings. They were intimate meetings. We walked in, we introduced ourselves, we talked about the field of orthotics and prosthetics. We prefaced it with what it is we were there to advocate on behalf of. And then we stated our case. In my own personal case, I shared my personal experience. I lost my leg young. I lost my leg when I was 14 years old due to osteosarcoma. And my first prosthesis were funded through Medi-Cal. And I told them, I said, look, if it weren't for that early intervention, I wouldn't be in the position I am now to care for my family, to be gainfully employed. The sort of services that we're asking for a continuation of are directly influence my ability to care for myself and others and become a pillar of my community. And, you know, Trevor made the point, I mean, he can speak to it himself, but, you know, the point is that it's become increasingly difficult to provide these services for these beneficiaries due to the fact that the reimbursement is so low and the cost of operation in the state of California, just like everywhere else, continues to grow. And the funds need to be there. They need to grow along with the demand as well as with the increasing requirement. So it was a message that was well taken. That I really sensed that they saw the importance of providing this level of care and keeping people moving. And I think it was a really productive day. A lot of good conversations were had. In most cases, two in particular that I can recall, they had no idea what orthotics and prosthetics even were. So we had to start with the 101. So a 5-minute spiel on what it is that we provide for our patients, and then the importance of continuing that care.
It was a powerful day. Thank you for sharing.
Sure.
And Spencer, you kind of had alluded to testimony. I really think that invite came out as a result of the rally. So I'm going to come back to you and ask you to fill everyone in on what that testimony was about.
Yeah, thanks, Linda. You know, we've been describing this day of the rally on the steps of the Capitol, and then subsequent, there were 8, one-on-one or intimate meetings with legislators, and you never know what you're going to step into. You never know what type of impact you're going to have along the way, but you're certainly not going to have any impact if you don't show up. And so we were there to be in person, to have the meetings, see what would happen. And coming out of that meeting, we, like Louise said, it seemed like people got it. The message resonated, but it's hard to tell what the next steps are. Lo and behold, Bryce gets a phone call from a representative of Senator Carolyn Menjivar, who is the chair of the Budget Subcommittee on Health. And they were putting together 2 panels. The first panel was a group of healthcare associations or provider associations that are currently receiving MCO tax investment. And then another panel of what I would consider deserving associations within healthcare that are seeking MCO tax investment. And to be, so the O&P field was basically asked to be represented. So COPA was the representative of O&P, and it was an honor to be singled out. There's no doubt in my mind that our visits after the rally led to this request for the O&P field to be represented. So something happened, and to my earlier point, you got to show up, and it worked. And so I was able to represent COPA and the field at a hearing in front of this budget subcommittee on health, and it was interesting. It was an opportunity for me to underscore the importance of O&P care, to illustrate the associated savings of investing in O&P care, and basically lay out an equation that said, by increasing rates for orthotic and prosthetic care, you will have more providers caring for Medi-Cal beneficiaries, and therefore you will spend less on healthcare. So this is a net positive for the state. The few other representatives of other healthcare providers at the table with me were like the Private Nursing Association and the Chiropractic Association, and they laid out similar cases. And at the end of the testimony, Senator Menjivar, who is the chair of this budget subcommittee, said, in her own words, there are some very deserving people at this table that should receive investment from these managed care organization tax dollars, and there's enough to go around, and basically made the case for us. So our message is resonating, and this is the long play. We have spent years building a foundation and cultivating relationships, and then having meaningful conversations and testimony, and it's clear that what we are doing is working. It's making it's raising eyebrows. It's getting us involved in subsequent conversations. So it was a good day for O&P, and I think it is an encouragement for us to continue fighting the good fight.
Right, and thank you for representing all of us, Spencer.
Happy to.
Bryce, I'm going to come back to you. We've been talking about the MCO tax and the efforts that we're playing. I know that earlier this month there was a little bit of a disheartening update. Can you give us a review of what that's about? Did we lose Bryce? Oh,
No, I'm here.
okay.
Yeah, thank you, Linda. So everything that happens in the legislative process is predicated on what we call joint rules, which are adopted by both chambers the first day that they reconvene for the legislative session. We are currently in the second year of a 2-year legislative session. And concurrently with movement of bills throughout the legislative process, the Assembly bills and the Senate bills, there's also a concurrent budget process that goes on. And what typically happens is the governor proposes his or her initial budget proposal January 10th of every year. And we do our budgets on a yearly basis. Then what happens is, like Spencer mentioned, the budget subcommittees on health, of which there are 2. Spencer mentioned Senator Carolyn Menjivar, who is a Democrat from Van Nuys, who chairs the Senate Budget Subcommittee on Health. Her counterpart in the Assembly Budget Subcommittee on Health, is chaired by a physician. Her name is Akilah Weber. She's an MD. She is an OBGYN from San Diego. And she is the daughter of our current California Secretary of State, Shirley Weber. So what typically happens between January and May is the budget subcommittees meet and they work up the governor's budget proposal. Now, keep in mind, the governor proposes the budget, but it is actually the legislature that passes the budget. So as you can imagine, there's a fair amount of negotiating, horse trading that goes on between January and May, and a lot of political posturing on what sort of things the state of California is going to choose to fund. And as you can imagine, the state of California funds those things that are of priority. What happens in May, around May 10th, and this was about a week or so ago, the governor comes out with what is called his or her May revision. We call it the May revise. And that is a revision of the budget that was proposed in January. However, it takes into account all the money that's in the bank that the state of California has collected from state taxes, which, as we know, are due in mid-April. So we take the tax receipts and we see whether or not the tax receipts and the funds that were received as of April match or don't match with what the governor was proposing in January. Oftentimes they don't match. Oftentimes the budget that's proposed in January is seen through rose-colored glasses. The governor is kind of like the candy man and wants to give everything to everybody. And then the real hard work starts in May when we actually figure out how much money we have in the bank. And then we have to figure out, and the legislature and the governor has to reconcile how we chew that up. The legislature must pass. It's in our state constitution. It was passed by initiative. The legislature must pass a budget and present it to the governor by June 15th. So as you can imagine, between May 10th and June 15th, which is the period we're in right now, is really where the rubber hits the road. I mentioned to you that there is a $27 billion budget deficit going into the next fiscal year. The governor's in his May revise has proposed slashing and cutting many of the programs and many of the services that we created, especially during the pandemic when we were flush with cash. One of the key provisions in the governor's budget to try and balance the budget is to sweep all of this MCO tax money going forward. It was about $9 billion total that we collected, that we were anticipating collecting from the MCO tax. The governor has proposed sweeping all of that money up and not providing increases for Medi-Cal providers, but using it to prop up and backfill the losses and the budget deficit with regards to eligibility for individuals in the Medi-Cal program, which is unfortunate. But the reason why we have such high Medi-Cal rolls is because California, more than any other state in the country, has fully implemented the ACA at the federal level. And we provide Medi-Cal coverage to everybody who's at 158% of federal poverty level. And the state of California has taken action over a number of years, and we now provide Medi-Cal coverage to any Californian, regardless of immigration status, as long as you are eligible. So the governor's first priority, as he is toying with running for president, wants to make sure that we maintain as much coverage as possible for the Medi-Cal beneficiaries. Now, all of us on this call, on the Zoom, understand that there is a giant chasm and Rubicon between having healthcare coverage and yet having access to that coverage. So what the legislature has been toying with over the last week or so is to try and claw back and recoup from the governor as much of those funds as we possibly can to continue the downward, the downstream increase in provider rates, particularly for us. Now, what sort of solutions do they have to do that? Not a lot. So they're going to have to propose deeper cuts in other areas around homelessness, around climate change, around environmental impact, many of the issues that is important to Californians. That's one thing. The other option is we have a rainy day fund, a budget rainy day fund that was created under then Governor Jerry Brown 2.0. And in that account balance is about $22 billion. So another area in which the legislature is considering negotiating with the governor on is finally tapping into those rainy day funds to help prop up the MCO tax. Now, it's a rainy day fund, and not only is it raining right now, quite frankly, it's storming. So there's a lot of political posturing, a lot of maneuvering. I've been spending hours and hours and hours at the Capitol trying to push for ways to claw back as much of the $7 billion in MCO tax dollars as possible to prop up Medi-Cal provider rates, particularly for orthotics and prosthetics. Now keep in mind, everybody else who was eligible for the tranche of funds this year also are kind of out of luck as of today. So we're competing again with the Hospital Association, community clinics, a lot of other people who were promised money in a handshake agreement, signed the dotted line last year that this was going to be the proposal going forward, only 6 months later to have the rug pulled out from underneath them. So as you can imagine, particularly in an election year, the legislature does not want to go back to their districts in July when they have their month-long summer recess and have to explain to their constituents why they're not getting increased access for Medi-Cal. So I anticipate not a full 9 million, but I anticipate a portion of the rainy day fund dollars being dedicated to the MCO tax. And our job is twice as difficult now because there was $1.5 billion on the table this year for the MCO tax. And remember, our cut of that from the state is about 14 million, which in budget speak, folks call that budget dust. I mean, $14 million out of a $302 billion budget is nothing. And the fact that we have done everything that Spencer has talked about, and the fact that we have hard data, studies that show that mobility saves. So yes, Linda, we got some bad news a couple of weeks ago, but everything that we've been doing over the last couple of years to amplify the issue, to elevate the issue, going to the media, being in these legislative districts, doing tours with patients and legislators in the districts, and what we call kind of emotionally wrecking them on these stories of some of our patients. We're just going to have to double down in the next couple of weeks to make sure we can keep our voices heard. And as part of that effort, we've launched a grassroots campaign to reach out to their legislators via email and letters, and Spencer may want to go into some more detail on that.
Yeah, thanks, Bryce.
Actually, yeah,
Go
go
ahead,
ahead,
Linda.
Spencer. I was going to say yes, Spencer.
So I've put in the chat the link that everyone can use to contact your legislator. We have engaged AOPA as a partner to use their software, and this could not be easier. You click the button, you click the link that takes you to AOPA site that says take survey. You click that button, you fill out 5 or 6 fields with your home information, not your business information. And based on your home address, the software links up your assembly member and your senator. And you click send. And the letter's already written for you, and it basically goes to both of them. And it says, I urge you to support investment in orthotic and prosthetic care for X, Y, and Z reasons. It's not an exaggeration. Will take you less than 1 minute. This is in contrast to what Luis was talking about with the intimate one-on-one meetings that were high quality. This is a quantity exercise. We want to flood the legislators with so many emails that they call Bryce up and say, please make it stop. It needs to be that heavy of a flow, because we are competing against other aspects of healthcare, and there are other deserving areas of healthcare that would like investment. However, I want my money on O&P. For everyone on this call, for every patient in California that needs care, we've got to make a change. And so this is where we need to, this is a true grassroots effort where we are asking you to join us. We're asking everyone in California to join us by not only doing it yourself, but by asking your colleagues to do it, by asking your family members to do it, your friends, your patients, their caregivers, honestly, anyone who cares about orthotics and prosthetics. So I work for Hanger, and I have spread this through all of California. Every employee in California is engaging with this. So that's a start. But there are a lot more non-Hanger people than there are Hanger people, and that's where we need the rest of the state to jump in. So maybe I can ask Trevor, what are you as a small business owner, what are you doing on your end to engage your team?
So what I've decided to do is pull a email report from our EMR for all of our patients that have given us emails. And we're gonna send out the link to the letter writing software to everybody that's ever given us an email. We've got we're accessing our Christmas list, so everybody that we've got as contacts in both our work emails and our my wife and I Hotmail and Gmail accounts are getting a link. So it's like Spencer said, you just let's like litter everybody we know with this, and give them the opportunity to send this letter in. It only takes a minute, and if I send it to 1,000 people and we get 30% of them to fill it out, it's big numbers, and that's just for every person on this screen. For every box on this screen, if we can get that email out to 1,000 people, and we get that 30% turnaround, that's a lot of letters to these legislators.
Yeah, thanks, Trevor. So I put the link in the chat. So if this is a perfect opportunity for multitasking, feel free to open up the little chat window, click the link, bing, 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 bing. I mean, you could be doing this while we're chatting. It's not even gonna hurt my feelings. This is where we as a small field need to think big. This is where we need to make ourselves bigger. And I feel like COPA has laid the groundwork, and now we need engagement. This is where we need to make our voices heard. AOPA has been very generous in allowing us to use their software to make it easy, because I recognize that handwriting letters and mailing to legislators is not going to happen. This is easy. So Linda, we've got 18 minutes left. Do you have more questions on your end, or should we ask the audience?
Let's open it up. What members of the audience have questions, either for more clarity on what the MCO tax is, what we need to be doing between now and the important June 15th, what COPA is doing, anything? We'd love to hear from you all. And I did put a challenge out there that once you've gone to the link, like Spencer said, multitask, and you've done your letter, please put a thumbs up. We're getting a few. Yay, I like it.
There's so I understand that, you know, as a clinician myself, the legislative side of what we do is a little foreign. So are there any questions about the process, or maybe next steps or anything that we can clarify?
Hey, I had a question. Up here in Redding, California, Jeff Zeller, Spectrum Prosthetics. Hey, I was wondering, is there any tactic that I know that up here we have rural healthcare designations on many of our, Medi-Cal clinics, and I was just wondering, is there any, sideline of something that we can apply for, get into the middle of when we're in those situations that might allow it? I know they get more reimbursement than someone who does not have that rural designation on office visits and stuff. Do you know anything about that?
Bryce, do you have from a legislative standpoint, a perspective, and then I'll offer mine up afterward?
Yeah, there hasn't been any specific discussion around what we're calling, these are called TRIs, or called targeted rate increases. There has not been a distinction between rural versus urban. There is some discussion around medically underserved. There's some discussion around that, maybe an amplified fee around those medically underserved, federally designated medically underserved areas, but nothing rural versus urban that I'm aware of.
Yeah, I was going to say the same, that there really has not been a distinction there, but I think it's an interesting angle. There are various facets to access to care, some of them being, metropolitan areas versus rural areas, some of them being even race related. There's some populations that are underserved compared to others, and so we are definitely trying to keep our finger on the pulse of the different angles. So that's what we've got for you. I wish the answer was a little more clear. So Jeff, thanks for the question. Anyone else?
Let's see, other questions. No other questions at this point.
I will say that this, COPA is going to keep fighting the good fight. That we strongly believe that we are in a position to do this. It wouldn't, the optics of Hanger doing this wouldn't be right, or a group of independent providers doing it, or a prosthetic manufacturer. It just, the optics aren't there. An association like COPA has the ability to do this, and really make a difference. And so for that reason, we're going to keep going down this path. But it does take support, and so support comes in the way of membership. Support comes in the way of, chipping in with with your time. Everyone on the COPA board is a volunteer, and we do it because we care. And so if you are interested in becoming a part of a committee or whatever it may be, a part of the bigger picture, let us know. We'd let you just drop a note in the chat, or go to the COPA website and let us know. We'll get you plugged in. That's no problem.
Great. I think it looks like we might be.
Let me have
go ahead.
one more question for Bryce. Bryce, do you know how the targeted rate increases affect the budgets of the MCOs themselves? Like, isn't there guidance from DHCS to the MCOs, but those MCOs have to create their own budgets, and how do the targeted rate increases affect their budgets?
The targeted rate increases is a pass-through. So the legislative language says that the managed care organizations must pay 87.5% of the Medicare rate for the current spend, which is on primary care, labor and delivery, and non-acute behavioral health services. The Department of Healthcare Services has come up with a list of codes, E&M codes. I think the list is close to 800 codes that are eligible for the increase, and that should be a direct pass-through. It's not something that is a windfall for the managed care organizations. Then you have to beg and grovel and negotiate for those fees. It's a direct pass-through at 87.5% of Medicare.
So when they're setting their budget, they know that for those 8 codes, and historically, you know, they had this much spend, and now they're going to have this much spend with it going from, you know, say it was 75% to 87.5%.
Correct.
Year over year. Does that make sense? Yeah.
I think that once this this Zoom link is closed, the chat will be gone. So I'd encourage you to, at a bare minimum, just kind of copy and paste it so that you have it. You can share it, throw it in an email, and use your patient list, use your your network, if you will. Share it on social media. This is all about raising our voice as a field. Let's say worst case scenario. We get this link out to a whole bunch of people, and we don't get the result we're looking for. We've still raised awareness to O&P. We still are, we're putting our field on the minds of legislators and other influential people, which I believe will pay dividends moving forward. So it's despite the challenges, there will always be challenges to getting a rate increase. Despite the challenges, it's worth it. So let's do what we can to spread the good word. Well, if there are no other questions, I think we'll wrap this one up. So, unless Linda, did you have anything else on your end? No?
You're not. We're good.
Okay. Thank you everyone for joining. Thank you for your interest and your involvement. Please join us in fighting the good fight. Let your legislators know that this is important, and please share with your network so they can do the same. We currently have approximately 200 people that have emailed their legislators, so 400 legislators have been contacted. I'd love to see that be 1,000 or more. And the sooner we do this, the better, because the closer we get to June 15th, the less likely change is to happen. We got to let them know now while they're making their decisions. Thank you, everyone. Really appreciate your involvement and your advocacy.